This is a process that has been marred by hiccups and confusion left, right and center, from the members of the National Assembly to the health care providers and also to the members of the public. She, Sha, Nif, which is which. There's so much confusion as far as this is concerned, and that is the conversation that we are having tonight to try and make sense of the pressing issues in the country. And this tonight is your healthcare. My name is Brian Amwai. Welcome to our continued coverage here on K24. And of course, to help make sense of these particular events, I'll be speaking to Honorable Duncan Madenge, who is the Member of Parliament in Nyeri Town and also sits in the Committee of Health in the National Assembly. Thank you so much for making time. And also, we do have Dr. Kahura Mundia, who is the Vice Chair, KMPDU. Thank you so much for making time tonight. And Dr. Catherine Nyongesa, CEO, Texas Cancer Center, and also an oncologist. Thank you so much for making time, lady. Sorry about that tonight. So I do want us to start from somewhere. I've been able to listen to conversations that have been happening in our other studio. And of course, when this particular broadcast started at 6 p.m. this particular evening, and you know, there's been a lot of questions from Kenyans and also stakeholders as far as this is concerned. Let me start with you, Honorable Madenge. This process, in terms of how it was rolled, was it doomed to fail from the onset?
Thank you, Brian. This system, and that is the shift from the provision of health services under the old system, which comprised of the National Health Insurance Fund, that basically had two components, or separated Kenyans into three components. One, salaried workers who by law were required to pay a certain contribution. I think it was 1,700 shillings from their salaries. Then there were another group of Kenyans who were voluntary contributors to the system, who were paying 500 shillings. And the rest of Kenyans who would only access health services if they paid from their pockets. The shift was designed to make every Kenyan able to access health services irrespective of your ability or inability to pay. That was a great shift. And therefore the thinking, including the set of legislations that were required to anchor that shift, was done, as you said, and enacted into law in 19th October 2023. Brian, besides being a legislator, I am now a holder of a Bachelor of Science in Health Systems Strengthening, which is a program based on the approach by WHO globally to guide countries in strengthening their health systems. The health systems strengthening is based on 6 pillars. 1, health leadership. 2, health finance. 3, health human resources. 4, health information systems. 5, health technologies and commodities. And 6, health services delivery. And therefore, when we sat in Parliament and looked at this shift, we took into consideration every one of these 6 pillars of health systems strengthening. NHIF was given by this law a 1-year period to allow for transition and seamless continuation of health services.
Why have we experienced confusion then, if at all that was the case? Because what we've been able to experience in the past 1 month is nothing close to what you're saying in terms of seamless transition.
I am among the first people to accept that we have experienced challenges. When we, with anything new, with the scaling of scope, with the movement from the old system to the new system, there were hiccups. people are talking a lot about the old system of NHIF. The old system of NHIF had only 3 components: the enterprise resource management, claims management, and registration. Under the new system, we have a widened scope over and above the 3 components of NHIF. We have a pharmaceutical information system, we have a telemedicine platform, we have a logistics supply chain platform, we have insurance management, we have claims management, we have learning, we have quality management, we have electronic medical record, we have cyber security, we have a data center, we have network connectivity, and therefore it is a highly improved, integrated healthcare information technology system. Is everything in that system working? No, it is works in progress. What were the main challenges in the 1 month?
It is work in progress, but at what expense?
The expense is the inclusion of every Kenyan. That it is at that expense.
Okay, let me bring in Dr. Kahura here. Work in progress according to Honorable Madenge there, but you know, what we've been able to experience and the stories that we've covered here, you know, the common mwananchi seated at home, trying to get access to healthcare, going to the hospital and being turned back at some extent, you know, decrying and saying this is not working, we need to go back to the old system because that's exactly what was working for us. Why are we being confused in this particular manner? What did we miss when we actually transiting from NHIF to, you know, shift?
Okay, thank you. First of all, I want to put it out that Kenya has had like the oldest healthcare system in the whole of Africa. Most of the countries have not progressed as we have had as Kenya. And even the Asian tigers, the persons we are trying to copy now, they one day came to us, and I hear stories that they have learned to improve their systems from what we had.
That
and
means
now
the
we are
old
copying
system or the new?
Like Singapore, some of their elements of how they run the healthcare, they learned some of those elements here. And today we are copying from them how to do it. So it becomes a little bit absurd. But the NHIF system was working from my point of view. And other than the legal challenges, that system could have still be optimized to provide the best care that is envisioned by the current government. It's only that there was a hurdle in the court cases. They decided to abandon ship and start up a new program. Now that transition now is where we are. That's why you actually look at the 2 legal frameworks, it's everything exactly the same. There's nothing that has been lost other than the spellings and the spirit of social health insurance, which was still the spirit since 1963, to at least provide people with a sense of care, especially the ones who are formally employed. And then from 1972 thereabouts, they introduced the voluntary schemes. And over the years since 2010, the NHIF has been going through reforms to be more attractive to the Kenyans so that Kenyans can onboard. And the management at that time has been working to actually just optimize that. And even when the Big Four agenda was being started, that was the way to go. But come the court cases of 2022, it became a little bit problematic. And I don't know how much stranglehold the cartels I hear had held the NHIF. And for that, they had to duplicate the framework and start anew.
Was that the best solution from where you sit?
Well, from my point of view, in a process whereby you want to do business continuity and operations, and the fact that you just want to still go with the same people, now you've taken the most expensive, most cheapest route to implement a project of this magnitude. The best could have been to just improve as sequentially as we had the old system. Okay. The new things keep on building up on them, and we'll arrive where we want. Not to drop ship and start a new project.
Dr. Catherine, a system that worked for close to 6 decades, then you know, we are in the process of actually transitioning from NHIF to SHIFT, because we will say we have actually transitioned if at all it was successful. But there's a lot of confusion that is happening within this particular process of actually, you know, moving from one system to the other. What has been your experience so far? And would you say it was a rushed process? And how it is being conducted to some extent might not actually work.
Oh, so thank you so much for having me. In the oncology space, I think from 2015, NHIF has been a game changer for cancer patients. That is the time they started accessing oncology packages, something that had never happened in our history. Okay. So NHIF was a good system, and now with the transition, for the cancer patients, we've seen a bit of just hiccups. Number one, maybe patient could arrive and they have not transitioned to SHA. They still have the old NHIF card. So there's a lot of misinformation out there about SHA, that it's not working, but actually it's working for cancer patients. And there is even an improvement whereby in the past you had to register, wait for 60 days before your card is matured so you can access service. So a cancer patient will go home and wait for 2 months. But now it is instant. They register today and they access benefits immediately. So that is a good thing from the transition to SHA. Okay. Another benefit I've seen is that there is patients can pay as little as 300 shillings based on your income level, and you are able to access service. So
the Kenyan Network of Cancer Organizations and Cancer Survivors Association of Kenya, petitioned the government to restore full access to cancer treatment services. If at all some of these things are working, then why would they go to this extent to demand that we actually, relook at the process of transiting from NHIF to SHA?
I think it has been a long journey moving from NHIF to SHA. There are a lot of processes, and from what I recall, I think the Kenya Kwanza government, what they wanted is really, what we are providing is basically NHIF. As you've been told, the framework, everything is the same, but it's supposed to be better. But now on that improvement, we've faced all these hiccups, but we are hoping the dust will settle soon and patients will be able to access.
Should we have improved on NHIF or transitioned entirely? Because from what you say, it was a game changer, especially for cancer patients since 2015, all the way to this particular moment. Then should we have improved on NHIF, or should we have entirely done, away with the NHIF and transition to SHA from where I sit?
Okay, personally, I think it is the same thing. We are talking about UHC, just renamed. Yeah, the vision, the goal is the same. That the government wants to provide good services to its citizens and to be all inclusive, whether you are employed, you are not employed. But the transition is the one that has had hiccups. But I'm sure as more people register, they understand the system. As more health care providers really also understand, because it's so much digitized. So when more people understand, I think so from
what I'm getting from you is that even the process in terms of sensitization of the members of the public was not properly done, even for people that actually get to give those particular services, and that's why you have this all confusion. Let me come to you, Dr. Honorable Madenge. At what point did we not realize that we needed to sensitize the public and every stakeholder involved before we actually roll this out? Should that not have been the main thing that we did before we actually thought of rolling it out, so that we get to avoid a lot of confusion that we're actually witnessing today?
The reality is that the sensitization, it may not be sufficient in scope, but the sensitization has been going on for quite some time. Okay. Way back in June, the short code for registration, *147# was already made public. But you look at the registration from June to October, when the rollover was kicked off, you find there was very little response to the information and the call to register. And Kenyans, we have to accept that I have a responsibility. It is my responsibility to register, preferably before I am sick, in readiness.
I want to bring you to this because you might throw it to the public, but also when it comes to even the parliamentarians themselves, there's that lack of understanding on this particular issue. Yesterday, we were listening to the debate in the National Assembly, and most of them even came out and said, we need more sensitization, organize a workshop for the parliamentarians so that we get to understand. And some said, we passed it here, we debated it, yes, but it was those in agreement actually passed the law without getting to understand what it really was. And this particular moment when the public now is coming out to ask questions, that's when the rubber meets the road.
It is not that the parliamentarians did not understand the law. It is the implementation part. The issue is not with the law, the way it is written, and the way things are supposed to be happening. It is in the implementation. And the implementation is the responsibility of a multi-sectoral approach. That is why we have the representatives of the national government at the grassroots, starting with wazee wa nyumba kumi, the assistant chiefs and the chiefs, required to go out and sensitize the public in the normal course of their duties. We have the 107,000 community health promoters who are visiting households in the course of their duties. They were supposed also to disseminate the information. However, that is what was supposed to happen. The reality is we have a gap. And that is the gap that
did not happen then.
It did not happen adequately. Certainly, from the numbers that have been released county by county, and I'm proud, Nyeri, where I come from, is leading at 153,000 registered members out of about 780,000. However, there's even a bigger gap. The number of people who are not salaried.
163,000 out of 700.
700. So that tells you we have a huge gap. We have just begun.
If that is what is leading, then there's a lot that needs to be done.
Exactly. And that is one of the reasons why we agree with the members of parliament who spoke yesterday. And we have asked the Ministry of Health and Social Health Authority to organize for a day or a half day when they will come and engage parliamentarians in a sitting that we call a kamukoji, so that that information in terms of exactly the rollout and how it is happening, and the role that parliamentarians can play in ensuring that this information gets to our people. Parliamentarians attend burials, they attend weddings, they attend churches, they attend fundraisers. If all members of parliament were able to grasp the package of what is supposed to happen, we immediately become evangelists for the system.
Okay, my question still will be in terms of a year later, why are we talking about parliamentarians being sensitized a year later after, the legislation was passed in 2019?
Because apparently, as parliamentarians, we stuck to our role of enacting the law, and once the law has been enacted and assented to by the president, then the relevant state department, in this case, the two state departments, Ministry of Medical Services and Ministry of Public Health, were supposed to take the lead and then on board other government agencies to help disseminate and cascade this information to every household. We have a gap there. We acknowledge all of us have a role to play. And I thank this media house today that you have dedicated virtually 4 hours of airtime for us to engage in this system.
All right. Now, Dr. Kauria, the main aim of this was to boost UHC, universal health coverage. But to some extent, with what we are seeing, and the argument out here will be, it's not really doing that. To some extent, it seems to be killing that. Would you agree?
Well, we are still headed where we need to go, which is to arrive at UHC. Because the United Nations and SDG 3 has pronounced themselves that that is where most of the countries should go.
Okay.
And we are trying to just head there. Now, going there is why now we're just faltering along the way. And our constitution provides for public participation.
Mm-hmm.
And we've argued so many cases on this since 2010. But the problems you're facing today, they are all around that subject matter, public participation.
Okay.
Now we are doing post-enactment and even post the court cases, public participation. Remember, even as you're speaking, there is a court case still lying cold in the Court of Appeal, and which we know will probably come out validating the whole process.
Mm-hmm.
But the consequences is Kenyans losing their lives and onboarding slow, and we had something that was working. And the good things that have been added on this Shiloh could have just been added on this side with less strain, with less sweating, and we still arrive faster with less consequences and with less losses at UHC. So we are still headed there.
Okay.
We just somehow lost in the directions.
If you say we are still headed there, does this take us a step back as far as that journey is concerned? Because when you look at NHIF and you say it was working, then we were headed to universal health coverage. Then maybe we were on the right track, if at all we go with what you're saying. Then with all this confusion that seems to be setting us, taking us a step back.
Well, you see, whatever is happening, even as of yesterday, sorry to say, Mheshimiwa, your chairperson, he should have been more clear on the processes and be more strict with how the law was being made. And then we'll not be suffering today this much. Because the noise and the amount of time spent yesterday in Parliament should never have happened. If everyone was on the same page, the way they reject finance bill was all over the place. Changing a system of healthcare is such a major affair that you don't just wake up today and say, we're going to give 1 year of transition. You can even transition out modules to just arrive where you want. And you will still get satisfaction with the results that you set out to do. So the vision is good. The implementation is a little bit sketchy. I don't know why.
What would have been the best way to transit from NHIF to SHA, if at all that was the end goal, not necessarily maintaining NHIF and try to improve it? If at all we just needed to transit from NHIF to SHA, what would have been the best way to go about it? Well,
one of them could probably have, you see right now we're doing both emergency, we are doing the emergency program, we're doing the primary healthcare program and the shift program, all of them at the same time, plus registrations, biometrics. So we could probably have tried to strengthen the community healthcare programs and the primary healthcare access and make that succeed. Once that succeeded, then we now move into the other levels of access. But we decided let's just risk it and go. Remember, even they had to migrate persons to this other new system. And then those persons migrated have not yet even verified their details. So there's a lot of hitches that could have been foreseen, and we will not be talking this much. Today we'll just be saying everyone is happy, everyone is happy to contribute, and it's working.
Okay.
So we're now spending more time quarreling instead of just enjoying the services.
Dr. Catherine, in all this confusion, you deal with cancer patients. What do they stand to lose?
Okay, the SHA is still quite young. It's only a month old. So for the patients, I encourage them to register, activate, and then they complete the process. Those who have paid in the previous NHIF, once they register in SHA, their money will be moved, and they'll only start paying because they're paying a year in advance. So if you paid until maybe June next year, so you'll only pay the remaining months. But the tariffs are calculated according to the income. And as little as 300 shillings, patients can access oncology care in public facilities and also in private facilities, but within the limits. And they can access it instantly.
Okay.
So I encourage them to join. They stand to benefit. And then when we were in the NHIF, what we used to see is that when patients exhaust their NHIF, they go home because they don't have anything to fall back to. So with SHA, the government has promised that there's that chronic fund that will kick in and support those patients.
Okay.
So we hope the gains are going to be
So does that mean that it covers everything as far as cancer patients are concerned? Is there no mishap to some with this one compared to NHIF?
I mean, it depends on where you go for your treatment. Yeah, in most public hospitals, it's supposed to be 100%. In private facilities, you have to work within the limits because they have set limits, like for oncology packages is up to 400,000. When you exhaust that, then you will have to move to the chronic fund. So if you access care which is affordable, you are able to get full cover within the package that has been given. And also patients can access MRI, CT scan, PET scan, bone scan. Some laboratory tests can be covered, biopsies. So there is still a lot that a patient can benefit.
Those are an outcry from patients that we covered here on, on the programs as the rollout actually started, because we are focusing on the chronic illnesses. And some of them did not, understand and had no nice words to say about the whole transition thing, because they thought that, we are putting their lives in danger to some extent. What was the missing communication in that particular extent to that?
I think patients came with an NHIF card to be treated when the systems had moved to SHA. So at that point, some had approvals from NHIF and they arrived and they said, we want to be treated with our previous approvals, and they were told no. So that communication was lacking. But it's not just patients alone. I think healthcare is a personal responsibility, and this government has shown us that we should all be proactive and register so that we can get benefits from this SHA.
Right.
But once the patients registered and moved to SHA, they were able to access treatment. And so far, I think the few I've interacted with, they are happy with SHA.
Okay. Dr. Honorable Madenge, I beg your pardon. 42 days since this was actually rolled, because it was rolled on the 1st of October. Today is actually the 13th, so it's 43 days there. And yet we've been able to see yesterday breaking news, acting CEO at SHA already suspended. And, some extent, what kind of picture does this paint to the public with a system that is struggling and people casting aspersions left, right, and center about it?
Now, let me take you back. About 3 weeks earlier, the chairman of the board, Dr. Olweni, was moved and replaced by Dr. Abdallah. We are looking at the system as a whole, and as we move on. We ask ourselves, are we moving at the right pace? If you find that you are the slowest coach and you are going to make everybody else, despite their capacity and ability, move at a better pace, then it makes sense to drop the slowest coach. I do not want to go into the merits or demerits, but clearly the fact that, to begin with, the first chair of the board was dropped, and now the CEO, the acting CEO, has been dropped. That is a red flag from where I sit, and it is possible that we have a more systemic problem with the entire leadership. Remember, I talked about the pillars, the 6 pillars, and I did start at the first pillar is leadership. So if the leadership cannot be able to carry the vision, win every other member of the team to own and run with the vision, then the leadership should go home. We will wait for the outcome of the investigation. That will say there's an issue of professional misconduct. We will wait for the report to come out.
Okay.
For me, it is so important at this point in time that nobody should start in the way and risk the lives of Kenyans in as far as health services are concerned.
But
in fact, the mere suspicion from where I sit is sufficient for somebody to be asked to step aside.
Okay, I believe the lives of Kenyans were already raised the moment we rolled out, and you know, because the acting CEO, who has now been suspended, was accused of, you know, did not handle the transition in a good manner to some extent. That led to the confusion that we've been able to experience. But one question was asked in with my colleague Kagina, with one of the panel that was sitting with Kagina in Studio B, and that was why do we have? Why was this CEO acting for a year? Why not confirm?
Exactly. So we had a board. So how come we have a board? We have the organizational structure of SHA already approved by the Public Service Commission and the Parastatus Regulatory Authority. So why did the board move to substantially fill that position? When you have people acting serving in an acting capacity, there is limited. You don't have the full mandate to work. People are afraid to make or are hesitant to make certain decisions, and therefore there is the question of the merit and demerit of it. So even now, the fact that rather than advertise immediately for a substantial recruitment of the entire management of SHA, we have people enacting a capacity. In myself is a weak link, and that is why I have said I don't think it was enough to remove just the chair of the board. Maybe the entire board should be reconstituted.
Okay. Dr. Lee, what does all this mean for the common Kenyan? Because you know, somebody is seated at home watching tonight and they're wondering, what I didn't want to move, but I've been moved. So why should I care from this particular onset moving forward? How is it going to affect me from where I sit?
Okay, thank you. Before I respond to that, I could state on the issues of management. Well, over the last like 15, 20 years, the NHIF board and the management, even if we project to the other groups, that's like NSSF, there's always those kind of conflicts between management and board. The board either wants to control the management, and the management does not want to do the right thing, or the management is gaming the board, and the wrangles keep on happening. Now that we're having a new baby, and the parents are fighting and wrangling, that means the baby will be abandoned, and I don't know now who will come and bring up this baby in the future to come. Because the dream shapers of this particular project, once they're taken out, it becomes a little bit kind of a different thing in the years to come. So we hope as the wrangles are happening, the vision will still be, and the achievement of UHC will still be realized. Now regarding the transitions, well, it did happen that persons were moved, their data was moved based on a regulation that was again passed in Parliament in a very quick fashion that none of us actually saw it. But it is what is allowing the transition and the data management to happen on this other side. So the information has gone to the Digital Health Authority, and the SHA authority is now using that information. And now the problem is persons have to come and validate. Remember, by the first week of transition, about less than 2 million persons had registered. And about 9 million persons were migrated. Now, out of these 9, I don't know who has the facts to tell us how many of these 9 million have verified their fingerprints, or it's just data that is existing in a database somewhere. But today here we have about 14 million. So you can make presumptions that the real verified data could be about maybe there are about 4 million verified with fingerprints. So we still have a lot to do, because these persons cannot still access services if they're not confirmed on that portal. They must confirm on their portal for the systems to work the right way.
Okay, back to my question, in how then, you know, people get to be affected with this particular, because some of these changes have been a very, you know, great concern to a lot of Kenyans. So if they are looking at this, you know, this whole process, what is it that they should be leaving out, and what is it that they should be picking from the conversation we are having tonight? Well,
to the Kenyans, the ones who are formally employed, they've got no choice. The law states mandatorily that they must be members of this contributory fund. And it's an obligation that is loaded onto the employer to remit the deductions they are. For the persons in the informal sector, who are many, and they're the ones who actually should benefit from this particular system. So the sellability of the project to them has not happened. And because they're being ambushed with a lot of information, they're becoming very hesitant, or they're acting hesitant to onboard. So we just hope that the process of onboarding will not take too long, because if it takes too long, the SHA funds collected from these other persons may not be enough to sustain the whole project. So we'll reach a place whereby maybe 2 to 3 years from today, whereby we'll start saying we don't have enough, and the persons just refuse to onboard. Then we'll start reworking the math again, what to do next. But if you begin on a good premise, it's easier for persons to just buy in and participate in your programs.
Okay.
Now, trust in the country is, it's nowhere to be found. So that is some of the challenges we're having.
All right.
But we hope it will clear out in the future.
When you started, you said this is a process that needed to onboard everyone, you know, from people from the lowest cadre all the way to the top. But the people that are salaried Kenyans, to some extent, feel like it is too much on their pay slip because it is the pay is still the same, but the deductions have increased to 4.45%.
Yeah, I agree that there is that feeling. But let me give you, I want to give my example. On a weekend, on a good weekend, in my office, I will receive between 6 and 8 invitations to go and fundraise for a hospital bill or for treatment costs, including for people who have been treated, they have passed on and their bodies are detained in hospitals. Today, last week, I gave an ultimatum in my office that for every member of the community who comes to the office and brings an invite for a fundraising for medical bills, the first question is, have you registered on SHA? They say yes, then they ask the second question, have you undergone the means testing and have you paid? I have one case in Madari where they were required, they were looking to raise 200,000 shillings for a patient who was already in hospital. And I told them, between raising 200,000 in a fundraiser and going through the assessment to determine how much you should pay to cater for you, your wife, and your children, and paying this bill for the husband of 200,000, which is cheaper. The following day, they went and they were assisted to go through the registration. They were required to pay 6,000 shillings. I sent them 3,000. Yesterday, the man was discharged. SHA, the card, paid for their membership, paid for them the entire bill of Kenya shillings, 200,000. So it's a matter of choice. Between mobilizing the entire village, we actually had no assurance that we would have raised the 200,000 for this family.
So the people that are feeling their pay slip is thinning, what happens to them? Because somebody feels something excess, you know, the more I earn, the more I pay. The more I earn, the more I pay. It is the same people who earn more who are actually contributing more in the fundraisings. That is the reality. Okay. So here it is a question of the burden. In UHC, under universal health coverage, some of us have to sacrifice a little bit more for those who cannot afford it to access it. All right, I want us to cross over to Mumbi in Studio B because I believe there's feedback from Kenyans. So Mumbi, what are people saying as far as this conversation is concerned, and whether the transition from NHIF to SHIF is actually a good move or still debatable based on what they're saying? What can you tell us?
Indeed, Brian, the conversation tonight has all been about the implementation of the Social Health Authority, SHA, and Kenyans raising concerns, some very dissatisfied with how the implementation has been going on. And we really do want to hear from Kenyans in various counties to hear what they have to say about the whole process, its implementation, the whole migration process from NHIF to now SHA. You can talk to us on our various social media platforms on Facebook, Kameme TV Kenya, as well as K24 TV, as well as on X or Twitter if you like, or at Kameme TV Kenya, as well as at K24 TV. Let's sample some of your feedback just coming in from our viewers tonight. Aaron Isika says, SHA itself is shambolic. Nothing good will come from it. Those are Aaron's views. Thank you so much for your views tonight. Doreen Njue says, SHA is not working even in government hospitals. I was in 2 dispensaries today and they're using cash here. In Ruiru, things are different. The truth is that it's not working. Asante sana for your views. Midhanga Johnny says, we have registered, but we're not getting the services. This is like giving someone food under condition. Don't eat that food. Is there any help provided to that person? This is what our government is doing to Kenyans. Midinga, thank you so much for your feedback tonight. Nyoike, it's an avenue to enrich themselves. They wanted NHIF to fail so people can get private insurances, which they somehow own through the back door. Thank you, Nyoike, for your feedback tonight. Keep roller, I hope I got that right. SHIF is far much better than NHIF. Just a few more things to put together and it will be the best insurance in Africa. Just remove cartels and other rogue officers slowing the process of implementation. Some packages need to be expanded so as Kenyans don't pay extra money. Asante sana for your views. Sipai Jim says the transition of NHIF to SHA is being sabotaged to fail. By extension, the president and Kenya Kwanza government deal with the cartels and rogue employees involved in the sabotage. Asante sana. All right, that name is quite cool. They rushed the CBC curriculum. We've never recovered from it. We're living with the consequences. Now they're rushing the SHA and we'll never recover from it. Thank you so much for your feedback tonight. Just Kenyans chipping in on the conversation tonight has been ongoing. And thank you all so much for your incredible feedback. Your insights have been a great contribution tonight. And we look forward to more discussions which will include you in the coming days. Brian, on the other end, will now take it from here. Thank you so much for your time. My name is Mumbi Chege. Have a great night. Brian, it's all yours.
Mumbi, thank you so much for the feedback from members of the public and exactly what they're saying as far as this conversation is concerned. And yes, my panel here, you've been able to hear and listen to what Kenyans have to say. We can be able to pick on how many people are actually supporting this. It's not a big number. So then brings us to the question, how is this information not getting out there entirely? Because you see, this, if at all we are going to be talking about public participation, then the views of the public is, seems to be coming in, and they are not in support of this particular transition. Let me start with you, Dr. Catherine. What do you make of what we just read and what we've been able to hear from Kenyans?
I think what I can make out is that every transition has its own teething problems. And it's a matter of time because we've seen one client who said it's one of the best.
Okay.
So we need to do more sensitization, both to the people who are employed. You'll be shocked. There are some people who they are employed, but they have not shifted to SHA. So people need to register more. We need to sensitize members of the public, make it more. You know, the way we did with COVID, I think a lot of efforts needs to be put in sensitizing people and telling them about the benefits.
Okay.
Without them knowing, it could be a hindrance to picking up the SHA.
So if you were asked, especially now that you deal with cancer patients, this is a positive thing for them. That's what you'll say.
That's what I can say. I mean, when we started, maybe the first few days it was hell, but with the time, it's one of the best.
Okay.
Because I saw patients waiting for months before they could access treatment, and now it is instant. Even for approvals, they are very efficient, more efficient than previously. You apply now, and you get an approval immediately and access care.
And
before you would wait for 3 working days.
Okay.
Yeah.
During the process of transition, did you get to experience any challenges personally at your organization?
Yeah, there were challenges. I mean, patients came and they left because they were not onboarded on SHA. They came knowing I'll be treated with my NHIF. So definitely there was a problem.
Okay.
Yeah.
How many? Most or just a few?
The first week, I mean, if you are not on, you had not registered on SHA, you will not get service.
Okay.
Yeah. So they were encouraged to register. And once more and more started registering, it is now okay. It's seamless, but there are times when the system is down.
All right.
And they experience those delays.
All right. I just want to pick from you in terms of when maybe you started noticing a difference in terms of now people having been very receptive to registering to SHA. At what point, because we are talking about the month of October, from the onset it was a little bit challenging from what you're saying.
Yeah.
Most patients that walked in, had to go back. So after how long did you start noticing a difference?
I would say within 1 week.
Okay.
The first 1 week was more difficult, but now currently things are more smooth.
Okay.
Yeah.
Now, there was that concern of, if somebody missed a session of chemo today, then, what then happens? How did you get to handle that?
Yeah, it's challenging, but we encourage them to register. And as soon as they registered, it was a matter of days and they got their treatment.
Okay.
Yeah.
All right, Dr. Kafuria, your sentiments on what Kenyans are saying as we wind up on this conversation?
Well, it's good that you're having these conversations because for a long time, no one wanted to talk about some of these things. The years before 2018, 2017, very few people wanted to talk about healthcare financing. It was still there, but now we are doing it boldly.
Yeah.
And as we keep learning and mislearning, we hope we don't make so many mistakes and so many people lose their lives.
Yeah.
Because if you take the wrong train, there's no point to continue going. Just alight at the next station and take the right train and go where you're supposed to go. So Kenyans on the informal sector, they need to be aware about what is happening. And they need to participate and contribute towards means testing and pay what they can as suggested by the means testing tool. And we hope that we'll be able to pool enough money to provide enough services at the primary care level, at the shift level, and the emergency care level. Because if we don't have enough, none of these services will work.
Okay.
And the other thing is that the services at levels 1, 2, 3, the primary health care, again, it's good you're having these conversations because that's where the other problem is. We don't have enough clinicians in those places.
Okay.
And for that, that means those persons will move to levels 4, 5, which is more expensive, and that becomes unsustainable. So we must optimize.
There's one comment here that we read, and somebody says that a
facilities.
dispensary, they were actually, they paid cash at a dispensary.
Yes, what is happening now, let's say if I'm in Nairobi, I'm supposed to pick a facility around Nairobi. If I visit elsewhere and I fall sick, if I go to be seen at that new location, I'm probably being told that is not where my money is at. But I should be able to access services because that is what primary healthcare should mean.
Okay.
That I'm able to access services wherever I go without being told you have to pick a particular facility because you lock movement by such locations.
All right. I've seen Honorable Madenge shaking his head as we wind up, Dr. Moshmer.
Yes, let me put clarity on the issue of health dispensaries and health centers. In the system, they are referred to as level 2 and level 3 health facilities. As long as you have registered using the short code *147#, you walk into any health center or dispensary, you are treated free without paying, because the primary health care fund is paid for by the taxpayer.
Okay.
So nobody should be asked to pay in any level 1, in any level 2 or level 3 health facility, health center or dispensary.
Okay.
And it doesn't matter whether you have traveled, because this is paid by the taxpayer. All they need to do is to find you in the system. The second one is that I'm going to appeal.
So what you're saying is that as long as you're in the system, you need to be able to access
in level 1 and level 2, the
okay.
primary health care, the primary health service providers.
All right.
Yes.
As you now, you come from a constituency that you said out of close to 700 and something thousand, 160 something are the people that have actually gotten to transition. And you're talking about sensitization. What is your plan for the people of Nyeri Town?
We are headed for recess in December, and I am personally going to go out deliberately, village by village, and engaging my people. As at now, I am already doing it. In fact, today, in the constituency at the Youth Empowerment Center, we had training for women groups that are receiving Uwezo Fund. That sensitization was already provided. Okay. I have appealed last week.
Are you getting any, not maybe positive reception when it comes to this particular transition?
Once we explain it, Kenyans are getting it. Okay. The question is how quick and how easy we are doing it, how often we are doing it. I am appealing to all of us to be deliberate. All of us, let's make it our responsibility. Let this be everybody's responsibility to ensure that every Kenyan is aware. Right. And let them know that you have two options. You can register yourself, or you can have assisted registration. The assisted registration is available in your neighborhood from the community health promoter.
All right, thank you so much, Honorable Duncan Mathenge, of course, a member of Parliament in Nyeri Town and also a member of the Health Committee in the National Assembly. Thank you so much for making time tonight. And of course, Dr. Kahura Mundia, who is the Vice Chair, KMPDU, do appreciate your time here tonight. And Dr. Catherine Nyongesa, CEO, Texas Cancer Center and oncologist. Thank you so much for making time tonight. All right, that does it for us here on K24, of course, special coverage, and Kameme TV. We had a special coverage tonight, tackling the pressing issues in the country, and that has to do with your health. Of course, the transition from NHIF to SHIF. What does that mean for you? Thank you so much for being part of this program tonight and engaging us on our socials at K24 TV and Kameme TV across social media platforms. On behalf of the entire team that made this one a success tonight, I do want to thank you so much for watching. Let's do this again when God says we do. Good night. My name is Brian Amwai.
Camarade nyonso na mokili ngai faya